In 1942, the United States military had a problem. Combat pilots were making fatal errors, not from enemy fire, not from mechanical failure, but from exhaustion. Sleep deprivation was degrading reaction times, judgment, and spatial orientation in the cockpit to the point where pilots were becoming a danger to themselves and their missions. The military needed a reliable method for pilots to fall asleep quickly, in any environment, under any conditions, regardless of stress or noise or discomfort, so they could rest during the brief windows available between missions. They commissioned a study. The result was a standardized sleep induction protocol that the military taught to pilots beginning in 1942. According to records from the program, after 6 weeks of practice, 96% of pilots could fall asleep within 2 minutes, in noisy environments, sitting upright in chairs, and in conditions of significant psychological stress. The technique costs nothing. It requires no medication, no device, no supplement, and no subscription. It has been in documented use for over 80 years. And the sleeping pill market in the United States generates approximately $500 million per year selling pharmaceutical solutions to a problem that a 2-minute physical and mental protocol addresses for the majority of people who practice it consistently. This is the story of what that protocol is, why it works, what the sleep industry has built in its absence from public awareness, and what the research says about the pharmacological alternatives being sold in its place. To understand why the military sleep technique works, you need to understand what actually prevents most people from falling asleep quickly. The inability to fall asleep fast is almost never a physiological problem with the sleep system itself. The human body's sleep drive, the accumulating adenosine pressure that builds throughout the day and produces the biological need for sleep, is a powerful and reliable mechanism. Under normal circumstances, a person who has been awake for 16 hours has substantial sleep pressure that should produce sleep onset within 15 to 20 minutes of attempting to sleep in a comfortable environment. What prevents this from happening is physiological arousal, the activation of the sympathetic nervous system that produces elevated heart rate, muscle tension, and the racing mental activity that most people experience as an inability to quiet their mind. Stress hormones maintain a state of physiological readiness that is incompatible with the parasympathetic shift required for sleep onset. The body is biologically prepared to sleep. The nervous system is preventing it from doing so. The military sleep technique addresses this directly by targeting the two physiological components of arousal simultaneously, muscle tension and cognitive activation, through a structured sequence that the nervous system responds to as a signal to down-regulate. This is not relaxation in the vague, hope-for-the-best sense. It is a specific sequence of physical and mental actions designed to activate the parasympathetic nervous system and clear the cognitive load that maintains arousal. Every element of the protocol has a physiological basis. The protocol proceeds in 2 stages. The first stage is physical. It targets the body from the top down, systematically releasing tension from every major muscle group in sequence. Begin with the face. The muscles of the face, the forehead, the muscles around the eyes, the jaw, are among the most tension-prone in the body because they are directly connected to emotional and cognitive state. Tension in the facial muscles is both a result of stress and a signal to the brain that stress is present. The sequence begins here because releasing facial tension sends an immediate signal to the nervous system that the stress state is resolving. Allow the forehead to smooth. Release the muscles around the eyes completely. Let them go heavy. Allow the jaw to drop slightly, releasing the tension in the masseter and temporalis muscles. Let the tongue fall to the bottom of the mouth. Move to the shoulders. The shoulders carry chronic tension for most people. They rise toward the ears in response to stress and frequently remain elevated without conscious awareness. Let them drop completely. Feel the weight of the arms pulling the shoulders down and away from the neck. Allow the arms to go heavy. Starting with the dominant arm, release the tension progressively from the shoulder down through the upper arm, the elbow, the forearm, the wrist, and the fingers. Then repeat with the other arm. The arm should feel heavy, warm, and completely without tension. Move to the chest. Take 1 slow breath in. On the exhale, allow the chest to relax completely. Feel the heart rate slow slightly. Do not force the breath. Allow it to become slow and shallow naturally as the body begins to down-regulate. Move to the legs. Release the thighs, allowing them to feel heavy against the surface beneath them. Release the calves. Release the feet. By the time you have completed this sequence, the body should be carrying significantly less physical tension than when you began. The entire physical stage takes approximately 60 to 90 seconds when practiced. New practitioners often find it takes longer because they are not yet proficient at identifying and releasing tension in each muscle group. With practice, the sequence becomes faster because the nervous system learns the pattern and begins responding to the cue of starting the sequence before each individual step is completed. The second stage is mental. It targets the cognitive activation that maintains arousal. The racing thoughts, the rehearsing of tomorrow's concerns, the replaying of today's events that most people experience as the inability to quiet the mind. The military protocol uses a specific technique for mental quieting, visualization of one of 3 scenarios held continuously for 10 seconds. The first scenario is lying in a canoe on a calm lake, looking up at a clear blue sky. Nothing is moving. The water is still. There is no wind. You hold this image continuously. The second scenario is lying in a black velvet hammock in a dark room. Complete darkness surrounds you. The hammock cradles you. Nothing else is present. You hold this image continuously. The third option, for people who find visual imagery difficult, is the repetition of the phrase "don't think, don't think, don't think," cycling continuously for 10 seconds. The purpose of these scenarios is not relaxation through pleasant imagery. It is cognitive displacement, replacing the active, stress-related thought patterns that maintain arousal with a single simple mental object that requires no emotional processing, no problem-solving, and no decision-making. The mind cannot simultaneously generate stress-activating thoughts and hold a simple neutral image. The image occupies the cognitive space that would otherwise be filled with the content maintaining arousal. This is the same mechanism that underlies the cognitive techniques used in clinical sleep therapy. Specifically, stimulus control and cognitive restructuring approaches used in cognitive behavioral therapy for insomnia, which is the evidence-based first-line treatment for chronic insomnia, according to the American Academy of Sleep Medicine. The military protocol is a simplified, self-administered version of the same underlying mechanism. The 96% success rate reported from the military program is remarkable enough to warrant examination because it exceeds the success rates of most pharmacological interventions for sleep onset difficulty. The caveat is that the 96% figure applies after 6 weeks of consistent practice. This is not a technique that works on the first attempt for most people. It is a technique that works reliably after it has been practiced sufficiently that the sequence has become conditioned. The body and mind begin responding to the initiation of the protocol before the protocol is complete, because the nervous system has learned what the sequence predicts. This conditioned response is the mechanism that makes the technique so fast once it is established. The beginning of the muscle relaxation sequence becomes a cue that the nervous system recognizes as preceding sleep onset, and it begins down-regulating before the full sequence is complete. The process accelerates with practice. The first week of practice produces modest results for most people. Sleep onset is somewhat faster, but the technique has not yet been conditioned. By week 3 or 4, most practitioners report significant improvement. By week 6, the majority have established the conditioned response that produces reliable 2-minute sleep onset. This learning curve is the reason the technique has not displaced pharmaceutical sleep aids, despite its effectiveness. People who struggle to sleep want relief tonight, not a 6-week training protocol. The sleeping pill produces a pharmacological effect immediately. The military technique produces a conditioned effect after consistent practice. For someone in acute sleep distress, the immediate pharmaceutical effect is more appealing regardless of what the long-term comparison looks like. The pharmaceutical sleep aid market deserves examination because the products in it have profiles that most consumers are not fully aware of. Prescription sleep medications, the benzodiazepines like temazepam and the Z-drugs like zolpidem produce sedation through different mechanisms but share several characteristics relevant to understanding what you are trading when you take them. They are effective at producing sleep onset. They do what they claim to do. But the sleep produced by many sleep medications is architecturally different from natural sleep. Benzodiazepines suppress slow-wave sleep, the deep restorative stage critical for physical recovery and immune function, and may suppress REM sleep as well. A person who falls asleep in 20 minutes after taking a sleep aid has shorter sleep onset than without the medication, but the sleep they get may be less restorative per hour than natural sleep. Z-drugs like zolpidem are more selective but have generated significant concern about their side effect profiles, including sleepwalking and complex sleep behaviors, morning after cognitive impairment, and tolerance development requiring increasing doses for the same effect. The FDA added a black box warning to zolpidem in 2019, specifically for complex sleep behaviors, including cases of sleep driving, sleep cooking, and sleep eating. Over-the-counter sleep aids, primarily diphenhydramine, the antihistamine in Benadryl, and Zizquil, produce sedation through histamine receptor blockade. They are effective but produce significant next-day grogginess, develop tolerance rapidly, typically within 3 to 4 days of consistent use, and in older adults have been associated with increased risk of cognitive impairment and dementia with long-term use. A study published in JAMA Internal Medicine found that regular use of anticholinergic drugs, including diphenhydramine, was associated with a significantly increased risk of dementia in older adults over a 10-year follow-up. The American Academy of Sleep Medicine's first-line recommendation for chronic insomnia is not medication. It is cognitive behavioral therapy for insomnia, a structured behavioral program that includes elements directly parallel to the military sleep technique. The recommendation reflects a body of evidence showing that CBTI produces more durable improvements in sleep than medication without the side effect profile and without the tolerance and dependence concerns. The military sleep technique is not CBTI, but it targets the same underlying mechanisms, physiological arousal and cognitive hyperactivation, through a self-administered protocol that requires no therapist, no prescription, no device, and no cost. Here is the complete protocol as practiced. Find a comfortable position. Lying down is optimal, but the military protocol was designed to work sitting upright as well. Close your eyes. Stage 1. Physical relaxation. Release the muscles of the face, forehead, eyes, jaw, tongue. Drop the shoulders completely. Release the arms progressively from shoulder to fingertips, dominant arm first, then the other. Take one slow breath and release the chest. Release the legs from thighs to feet, especially in early practice. Notice them without engaging with them and return to the scenario. If the technique has been practiced long enough to produce conditioned sleep onset, you will fall asleep during or shortly after the mental stage. If you are still practicing and the conditioned response has not yet been established, the technique will still produce a significantly more relaxed physiological state than you started with, which supports faster natural sleep onset even before the full 2-minute result is achieved. Practice every night regardless of whether you feel it is working. The conditioning requires repetition. The benefit accumulates invisibly across the practice period and becomes apparent at the point where the conditioned response is established. Here is the synthesis. Most sleep onset difficulty is not a physiological deficiency in the sleep system. It is sympathetic nervous system arousal, muscle tension, and cognitive activation, preventing the parasympathetic shift that produces sleep. The military sleep technique addresses both components directly through a structured sequence that conditions the nervous system to shift towards sleep onset when the protocol is initiated. It works for 96% of consistent practitioners after 6 weeks. It costs nothing. It produces no next-day grogginess, no tolerance, no dependence, no architectural disruption of sleep stages, and no association with dementia in long-term use. The pharmaceutical sleep aid market generates $500 million per year selling pharmacological sedation to people who have not been told that a conditioned behavioral protocol, developed for combat pilots, validated in military research, and parallel to the evidence-based clinical treatment for insomnia, is available to anyone who practices it. The technique is 80 years old. It was classified as a military training method rather than a consumer product. It was never marketed. It has no distribution channel and no advertising budget, and no one in the $500 million industry that profits from your inability to fall asleep has any incentive to tell you it exists. If this changed how you think about reaching for the Ziz quill tonight, hit the like button, share it with someone who has been taking sleep aids for months, and subscribe for more of what the industry prefers you never find out.